Hi everyone, my name is Renee Kreidl. I'm a geriatric fellow here at UCI, and today I'm going to be presenting cognitive impairment cases. All right, so first case, which of the following statements about dementia is false? There may be more than one correct answer. A, in order to be diagnosed with dementia, the severity has to be great enough to affect daily life. B, the 5 cognitive domains that are measured in cognitive tests are short-term memory, long-term memory, reasoning and complex tasks, visual, spatial, and personality. C, if a patient is diagnosed with major neurocognitive disorder, it means they have dementia. And D, in order to be diagnosed with dementia, symptoms must not be explained by delirium or a psychiatric disorder. So which one of these are false? So it was answer B that was false. So going back to answer B, it stated that the cognitive domains were short-term memory, long-term memory, reasoning and complex tasks, visual, spatial, and personality. I listed here the definition of dementia per the National Institute on Aging and the DSM-5. Per the National Institute on Aging, the 5 major cognitive domains that are tested and should be looked at when considering a chronic acquired decline, such as dementia, are memory, reasoning and complex tasks, visual spatial, language, which was not mentioned in the incorrect answer, and personality, and it must be sufficient enough to affect daily life. The DSM-5 major neurocognitive disorder is the newer term for dementia, and it also mentions that it has to be a substantial decline expressed by the patient or a reliable informant or clinician observations in one or more cognitive domains that is not exclusively during delirium or better explained by another mental disorder. And it has to interfere with dependence, similar to the NIA definition of affecting daily life. So interfering with independence, this might mean affecting IADLs, so instrumental activities of daily living, such as using a telephone, or ADLs if more severe, such as toileting. All right, so dementia should not be confused with MCI, which is mild cognitive disorder. Per the DSM-5, this is the same as major neurocognitive disorder, except it's only a modest decline from a previous level of performance, and it does not interfere with one's independence. However, the patient may need greater effort, compensatory strategies, such as keeping a very detailed calendar, sticky notes, etc., or accommodation to maintain independence. And you can think of MCI in 2 different categories. One is amnestic versus non-amnestic. Amnestic meaning memory is primarily affected. There is a 10 to 15% chance per year that MCI will convert into dementia. Dementia should also not be confused with delirium. So delirium per DSM-5 is a disturbance in attention, so reduced ability to direct, focus, sustain, and shift attention, and orientation to the environment that develops over a relatively short period of time, so hours to days. And that is an acute change from baseline that isn't explained by other neurocognitive disorders and tends to fluctuate during the day. You also need to have a change in an additional cognitive domain, such as a memory deficit, disorientation, or language disturbance or perceptual disturbance, such as hallucinations. The one caveat here is if a patient has severely reduced level of arousal, i.e. they're in a coma, they cannot be diagnosed with delirium. Okay, on to our second question. You are practicing in an outpatient primary care clinic and have had a number of patients coming in for memory problems. Listed below are clinical scenarios and some form of cognitive testing. Choose the pair that is incorrect. There may be more than one correct answer. So option A, you have an English-speaking 83-year-old male. Highest level of education is some college, hospitalized after a fall, who has started hallucinating last night after surgery. He has a diagnosis of mild dementia, and the cognitive test paired with that is CAM. Option B, English-speaking 78-year-old female, highest level of education obtained 10th grade with CID, uncontrolled diabetes, complicated by retinopathy, now blind, who was brought in by her daughter for memory concerns. MoCA, blind version is the cognitive test. Option C, you have a Spanish-speaking 72-year-old female, highest level of education obtained was 4th grade, who gradually stopped cooking and cleaning around her house and had her electricity and natural gas shut off because she did not pay her bills. MoCA A. In option D, you have a Spanish-speaking 70-year-old female with the highest level of education college degree who has been unable to drive anymore because she keeps on getting lost in her own neighborhood and has had 2 car accidents in the past year. MoCA B. So again, you're looking for the incorrect answer. All right, so the answers here we're looking for are C and D. So going back to C, so you have a Spanish-speaking female and her highest level of education is 4th grade. So MoCA A would not be appropriate for her. MoCA B would be more appropriate. MoCA B was made for, as you can see here, explained here, more appropriate for people who are illiterate or have a less than 5th grade education. And MoCA A would be more appropriate for higher levels of education. So C and D would be switched. Your lady in option C would need a MoCA B, and your option option D would be MoCA A, would be more appropriate for her. CAM that was mentioned in option A here, your English-speaking 83-year-old male who has mild dementia but is now more confused. So CAM would be most appropriate, and just to review, CAM stands for Confusion Assessment Method. It's listed to the right here. It includes the acute onset and fluctuating course in attention, distractibility, disorganized thinking, illogical or unclear ideas, and alteration in consciousness. So for delirium, again, you need 1 plus 2, and then you need either 3 or 4 present. And sometimes in such cases, when you have a patient in the hospital with underlying dementia and you have delirium on top of that, sometimes you may do an MSE or a mini-cog to help you go through the CAM algorithm, but the main testing would be CAM that we're looking for. Okay, so what does a PCP need to know about cognitive tests? There's a couple of different things. So they're often labeled as screening tests. However, the U.S. Preventative Services Task Force, which we go by for a lot of our primary care quality measures, states that there's insufficient evidence to fully weigh risks versus benefits of screening for cognitive impairment. That being said, if you were to screen for cognitive impairment, the shorter cognitive tests are more doable for a PCP. This includes the 3-item recall, the mini-cog, and the memory impairment screen, or MIS. There are advantages and disadvantages to both, or to all of these. For the MIS, you do have to be literate, English speaking, and 4 out of 8 or less would be considered impairment on that test. For the mini-cog, it requires a clock drawing, so you need a patient with adequate vision. So this would be 3 out of 5 would be cognitive impairment. And 3-item recall, you can use with patients who are illiterate or a foreign speaker, just use an interpreter, and or blind. So 2 out of 3 or less would be considered possible cognitive impairment and should make you think that they need further testing and investigation. Just a reminder, the mini cog is 2 components. It's a 3-item recall plus the clock. 3-item recall is just 3-item recall. Okay. The longer cognitive tests that are often labeled as screening tests are most often used for evaluating a patient with a cognitive complaint, so not a true screening test. Cognitive complaints could include short-term memory loss, personality change late in life, sometimes word finding difficulty. The most common ones that I see are MoCA, which stands for Montreal Cognitive Assessment. And there's a couple different varieties including MoCA A, MoCA B, which we explained the difference in before, and then MoCA blind version. There's also the MMSE, which I'm sure a lot of you are familiar with, the CASI, or Cognitive Assessment Screening Instrument. There's a longer CASI version that is often used by neuropsychologists, including at UCI, that's out of 100 points and takes about an hour or so to administer. And then there's the CASI short version that sometimes folks in the Santa Ana Clinic do use. And there's also SLUMS, which is used less commonly, I've seen. It's a St. Louis University mental status exam. And just as a reminder, these tests cannot tell you if a patient has dementia or not. You must look at the entire clinical picture. So in terms of other things that you need to know, so the MMSE, which stands for, again, Mini Mental Status Exam, was made in 1975, so it's an older test. It takes about 7 to 8 minutes, which not very long, and it's better for evaluating patients that you think are more moderately cognitively impaired. It is out of 30 points, with normal for people with a high school degree is 24 or above. If you have an only 8th grade education, 22 or above may still be normal. The test is language heavy, so dementias that tend to have an other cognitive deficit first, such as in Lewy body dementia where language may be preserved, you may miss those if you use an MMSE on that kind of patient. You also need to have a patient who is English speaking and has good vision, and the test form is easily printed out from the internet. I have included links to all of the different cognitive tests at the end of this presentation. Okay, moving on to the MoCA. The MoCA, compared to the MMSE, is a newer test. It was created in 1994. The one I see geriatricians use the most. It's more sensitive than the MMSE, so it is better for picking up mild cognitive impairment. It does take longer, about 10 to 12 minutes to administer, and you add a point if your patient has 12 years or less of education. That should be a less than or equal sign. So if they graduated high school and didn't have any additional education, you still give them an extra point. For MoCA A, 26 or greater is normal, 18 to 25 is mildly impaired, 10 to 17 moderately, and 9 or less is severe. Unfortunately, the MoCA was copyrighted after Trump aced the test you may have heard of in 2018. And looking at their website, they do say that training and certification are required for administering the test, but it also says that universities or health professionals, clinics can use the MoCA. You use it, reproduce it, distribute it without permission if it is for clinical use. So technically you can still use it. You can still access the test forms via Google search. And just to go through the different kinds of MOCAs, again, MOCA A is for more educated patients. There is an alternative version of a MOCA. If you have a patient who, let's say, took a MOCA recently and remembers some of the answers, or looks like they are basically remembering what they had done earlier, you can use that alternative version. MOCA B, again, is for those who are illiterate or have less than 5 years of education or less. Instead of the 26 for MOCA A, 25 or greater is considered normal on the MOCA B. And for the MOCA blind, it's basically the same version as MOCA A or MOCA B, but the components where you have to look at the image or draw things, those are cut out. So the test ends up being out of 22 points, but for final scoring, you use some division and multiplication and you convert to out of 30. I will warn you that the instructions for all of these cognitive tests are somewhat specific, and as you're administering more of these MOCAs, you will run into the problem where you have a patient who maybe had a clock drawing where the hands were of equal length, and you're wondering, should I still score that? Does that still count? The answer, by the way, is yes. If the hands are pointing to the correct numbers, they still count. So I would recommend reading the instructions before administering the test. And the more you can practice, the better. Okay, so question 3. For your patient in scenario B, so this was your English-speaking 78-year-old female, highest level of education, 10th grade with CAD. I think I actually changed it a little bit. I said less than 5th grade education before. Okay, so this lady is slightly different. 10th grade education, CAD, diabetes. She's blind, brought in by her daughter for memory concerns. You already did some testing, cognitive testing on her, and you're trying to figure out what labs or imaging you do not need to order for this patient. So CBC, CMP, RPR, vitamin B12, and brain MRI without contrast. So which one of these do you not need to order? And the answer is C. So C, it was the RPR. So per the American Academy of Neurology, tests you should perform are a depression screening, such as the Geriatric Depression Scale, CBC, glucose, serum electrolytes, BUN, creatinine, liver function tests, which is essentially a CMP, thyroid function tests, such as a TSH, serum vitamin B12 levels, and an RPR or VDRL test for syphilis should be considered for patients who are at higher risk of contracting syphilis or in areas of high prevalence of syphilis, but doesn't need to be done in every single case of a patient you're considering for dementia diagnosis. Okay, so how do I know if I need to order imaging? This is how I've seen geriatricians approach it, at least at UCI. So consider an MRI without contrast for a patient with a specific neurological deficit, such as right-sided weakness or significant cardiovascular disease. Also an atypical type of dementia that's not consistent with the most common form of dementia, which is Alzheimer's disease, or if it's an early onset dementia, so less than age 65. If an MRI is cost prohibitive, you can do a head CT without contrast, but do know that it will be less sensitive for picking up prior CVAs. And just to give you some additional information to help you decide whether or not you need to do imaging, the American College of Radiology lists both MRI or head CT without contrast as usually appropriate, which is their highest rating for initial imaging in suspected Alzheimer's. frontotemporal dementia, dementia with Lewy bodies, vascular dementia, and suspected NPH. So note it's a little bit different than what I see in general. So they say for initial imaging and suspected Alzheimer's, even then you would do imaging. So given that information, make your decision, figure out how you want to run your practice. But I note that the patient we were talking about has multiple risk factors for CVA, uncontrolled diabetes. She also had CAD. So in this case, I would say get an MRI without contrast. It would be appropriate. Okay, question 4. Which of the following patients are least likely to have mild cognitive impairment or dementia, known as major neurocognitive disorder again? Is it A, a 78-year-old male who misplaces his keys regularly and finds them later in the freezer or closet, so fairly odd places? Is it option B, a 68-year-old female getting fired from her job for missing multiple meetings and forgetting to respond to emails? Is it C, a 64-year-old woman with decreased energy, apathy, and frequent crying, who has no prior history of depression? Or is it D, a 70-year-old male, full-time mailman? He comes to you saying he has intermittent word finding difficulties. So, doc, sometimes when I'm talking, I just can't remember a word. Sometimes I may remember them later, but it's really bothering me. Might be a presentation. Okay, so which one is least likely to have these problems? Okay, so the correct answer was D. So it was our mailman who is still working without problems, who has intermittent word finding difficulties. So note the top 10 warning signs of Alzheimer's dementia per the Alzheimer's Association include memory loss that affects job skills, difficulty performing familiar tasks, problems with language, which you might say, but our mailman had problems with language. We'll get to that in the next slide. Disorientation to time or place, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in mood or behavior, such as our lady with new onset depression in late life, changes in personality, such as being less inhibited or inappropriate in certain situations, and a loss of initiative. So they're just not starting activities, perhaps starting conversations like they used to. Okay, so this information I got from the UCLA Geriatrics Review course, which is pretty good, back in 2019 in the beginning of my fellowship. And they had listed signs that it is normal aging and not dementia. So if your patient is more concerned than the family, they can actually describe details of forgetfulness. They have intact recent memory for important events. Classically, word finding difficulties are the big thing that they're concerned with, and function is preserved. That's a key one. Okay, so question number 5. You have a patient presenting to your clinic for first-time evaluation of cognition problems. When listening to the history, which of the following symptoms or characteristics should make you suspicious that there's a dementia going on other than the most common Alzheimer's disease? And again, maybe more than one correct answer. Is it A, auditory hallucinations, B, fluctuating levels of wakefulness, C, gradual onset, D, depression, or E, short-term memory loss? Okay, so the correct answer here was B. So the fluctuating levels of wakefulness and concentration, attention, and alertness from day to day, and sometimes even throughout the day, are a classic presentation of dementia with Lewy bodies. Vivid visual hallucinations are often present in dementia with Lewy bodies as well. Some examples of vivid visual hallucinations I have had complained of in my patients are seeing rabbits in the backyard, seeing children running around their house, seeing cactuses by their bedside. But the very most classic presentation would be vivid visual hallucinations of people in this scenario. All of the other symptoms that were listed are consistent with Alzheimer's dementia. So going back for a minute, auditory hallucinations are actually consistent with Alzheimer's dementia. The gradual onset, depression, especially becoming more withdrawn, and short-term memory loss. Those are all classic for Alzheimer's. All right, free response. So name as many dementia syndrome types as you can. There's a lot of different things that fit under the dementia umbrella. Give you a couple seconds to think about that. Okay, so how many did you get? Did you get Alzheimer's, early and late onset? So again, the cutoff is age 65. Lewy body dementia, frontotemporal dementia, which classically has pretty extreme variations in personality or changes in personality. Huntington's disease, so a lot of movement problems that accompany that. Mixed dementia, which can be most commonly Alzheimer's and vascular dementia. More research is showing that there are likely very few cases of just vascular, just Alzheimer's, and there are a lot of more mixed cases of those two. Normal pressure hydrocephalus, Parkinson's disease, Korsakoff syndrome associated with long-term alcohol use, Creutzfeldt-Jakob syndrome, which is prion disease, very rare, HIV-related dementia, or neurosyphilis. A note on normal pressure hydrocephalus. Be careful on this one. Sometimes when you get imaging, they may say that the ventricles are enlarged, and they say consider normal pressure hydrocephalus. However, make sure that you look at the entire clinical picture, which is the classic wet, wobbly, wacky, wet meaning urinary incontinence, wobbly meaning gait disturbance, frequent falls, difficulty with balance, and then wacky, unfortunately, being dementia and cognitive changes. So even if you see enlarged ventricles on the imaging, it does not mean that they have normal pressure hydrocephalus, especially if they have a lot of overall atrophy. You may see the term ex vacuo on the imaging, which makes you think that it's just enlargement of the ventricles due to overall brain atrophy. When in doubt with that one, talk to your neurologist. Okay. All right, another key tool that I'm going to have you look at here is the CARE toolkit. I believe it was developed by UCLA. Basically, it's a table here that I thought was pretty good. So that's one that I've found that differentiates different kinds of common dementias. And again, I list the way to find this at the end of the presentation as a link. Question number 6, which of the following techniques on improving functional performance and reducing problem behaviors associated with dementia do not have either strong or good level of evidence and efficacy? Is it A, behavioral modification, scheduled toileting, prompted voiding to reduce urinary incontinence? Is it B, walking or other forms of light exercise? Is it C, graded assistance, practice, and positive reinforcement to increase functional independence? Is it D, pet therapy? Or is it E, music, especially during meals and bathing? So which one of these don't have strong or good level of efficacy? The answer was D. So pet therapy can still be employed, but weak strength of evidence. The other interventions have either strong or a good level of evidence per the American Association of Neurology, again. And there are a number of other excellent resources that you can refer your patient's caregivers to help them out with behavioral problems. So Alzheimer's Association, they have some educational courses such as the Savvy Caregiver. There's Alzheimer's Orange County, which broke off from the main National Alzheimer's Association organization. There are UCLA caregiver training videos, and these are divided specifically by specific behaviors such as repetitive questions, repetitive like picking or activities at home, urinary incontinence, that sort of thing. The VA rural health caregiver videos also are very useful. And don't forget your clinical social worker. Okay, question 7. True or false? Physicians practicing in California are not required to inform the state of a patient who has mild dementia, is driving locally, and has had no car accidents in the past year. So true or false? All right, so that is false. So physicians in the state of California who are practicing are mandated to report dementia, also known as major neurocognitive disorder, if the patient is still driving regardless of the dementia severity. You are not required to submit a report if the patient has mild cognitive impairment. But if you have concerns about the patient driving, you should still submit a request for driver re-examination form. So there are two main ways to report a patient with dementia to the state. It's either the request for a driver re-examination form, which is the most common one that I've seen. And on that, you can request to remain anonymous, but honestly, it is a good policy to explain to your patient and the family or caregivers that you're concerned about the safety and letting the state know that you have dementia as mandated by law. And you can let them know that this does not automatically remove the license. And we as physicians are not in charge of saying you are allowed to have a license or not, just that the DMV will do a further evaluation. They may just put restrictions on their driver's license. I did have one patient who was allowed to drive, but so long as he had someone else who was not cognitively impaired in the car. That's about it. Oh, just in terms of figuring out if you need to report the patient to the state, really make sure that you know their activities of daily living and instrumental activities of daily living, because that will really, really help you determine between mild cognitive impairment and dementia. That is the key branching point to figuring out if you need to report this patient to the state of California. Okay, so I got a question about treatment for you. So, which of the following is an incorrect matching of a dementia medication and its FDA approved indication? Is it A, donepezil, and mild to severe Alzheimer's dementia? Is it rivastigmine with mild to moderate Parkinson's dementia? Is it galantamine with mild to moderate Alzheimer's dementia? Is it memantine with mild to moderate Parkinson's dementia, or is it rivastigmine again, mild to moderate Alzheimer's? And just some abbreviations for later on. Acetylcholinesterase inhibitors, which are the donepezil, rivastigmine, and galantamine, and the NMDA receptor antagonists, which are only memantine currently. Okay, so the answer here, the pair that was incorrect together, was answer D. So going back to D, we said memantine with mild to moderate Parkinson's dementia. That was incorrect. So memantine is only FDA approved for moderate to severe Alzheimer's dementia, not Parkinson's dementia. And I'm going to have a slide here that shows FDA and common non-FDA approved uses. And I just threw this picture in I thought was pretty interesting. You can see a normal brain and a brain with Alzheimer's. You can see the sulci are a lot deeper and the overall brain atrophy. Dementia medication indications. Okay, so on the left here we have the FDA approved indications, but really there are a lot of common off-label uses. So to summarize, so you don't have to memorize them individually, all of this acetylcholinesterase inhibitors, they're all approved for mild to moderate Alzheimer's dementia. Donepezil is the one that has the added FDA indication of severe, so anywhere from mild to severe Alzheimer's dementia. And the doses for donepezil, 10 milligrams per day, usually start off with 5, although I've seen as low as 2.5 milligrams per day started. And then the recommended dosage for moderate to severe is 23 milligrams a day, up to. Rivastigmine does have the added FDA indication for mild to moderate Parkinson's dementia. And memantine is only FDA approved again for moderate to severe Alzheimer's dementia. Note that vascular or mixed vascular Alzheimer's dementia is often used for, these medications are often used for those kinds of dementias. And in regards to memantine, sometimes you have a patient with, let's say, symptomatic bradycardia or history of atrial fibrillation, CAD, a number of heart conditions, or a patient with weight loss, significant weight loss, those are all contraindications to starting an acetylcholinesterase inhibitor. So at that point, memantine might be more appropriate, even if it's just mild Alzheimer's dementia. Donepezil and galantamine are often used for Parkinson's and Lewy body dementia. So technically, rivastigmine only one approved for mild to moderate Parkinson's, but the donepezil and galantamine have been used for Parkinson's and Lewy bodies. And so I haven't seen this a ton, but acetylcholinesterase inhibitors for mild cognitive impairment. So the step that's often before a stage before true dementia. Some people do use it. The data isn't great, but ultimately it is up to you as an individual prescriber to figure out how you want to manage things. Couple other notes on this is when thinking about prescribing medications for the patient, you want to let them know what the limitations and positives are to prescribing these medications. So these medications are, I tell patients, are not miracle drugs. They are not going to significantly improve your loved one's performance in terms of just day-to-day thinking and memory. What you may see are preserved activities of daily living, preserved function for longer periods of time. So being able to feed themselves or toilet themselves for a longer period of time. And also there has been some data suggesting that people who are on either the acetylcholinesterase inhibitors or the memantine drugs do stay at home longer and are institutionalized, like at a nursing home or memory care facility, longer down their course of dementia. So they stay at home longer, basically, is what you can tell the caregivers might be a possibility. Oh, actually, and another thing, things to warn your patients about side effects. The acetylcholinesterase inhibitors have significant GI effects, so think nausea, vomiting, upset stomach, diarrhea, but they usually resolve within the first couple of weeks. Make sure you eat them or you take them with food, which can lessen the side effects, but if they're too bad, that would be an indication to stop the medication. And then with memantine, you can see dizziness. That would be the biggest side effect to consider. Okay, and these are some resources that I have mentioned already, including the instructions. Yeah, I wasn't able to find the Cassie, unfortunately. Oh, quick note on this one. Alzheimer's helpline is 24/7, so please let your caregivers know that they are quite available. And some videos on behavioral problems. FAST would be worth looking up. I didn't go through it specifically in this PowerPoint, but it's the Alzheimer's Severity Score. And then the Global Deterioration Score is for dementias other than Alzheimer's. Thank you very much.